Radius and ulna shaft fractures. Anatomy. Forearm acts as a ring. Ulna serves as an axis, while the radius rotates laterally during supination and pronation. Interosseous membrane. Extends downward medially from the radius to the ulna. Central band is the primary stabilizing portion. Pathological anatomy. Shortening of one bone may lead to a. Fracture of the other bone. b. Dislocation of the proximal radioulnar joint, PRUJ, or distal radioulnar joint, DRUJ. Mechanism of deformity based on fracture level. Proximal 1/3 fractures. Radius supinated and flexed, biceps. Ulna pronated, pronator teres and supinator. Middle 1/3 fractures. Radius neutral, affected by supinator and pronator teres. Ulna pronated, pronator quadratus. Distal 1/3 fractures. Radius dorsiflexed and radially deviated, brachioradialis. Classification. 1. AU classification. 22A. Simple fracture. 22B. Wedge fracture. 22C. Complex fracture. A1C3. Subtypes based on bone involvement and fracture characteristics. 2. Descriptive classification. Nightstick fracture. Isolated distal 2/3 ulna fracture. Clinical presentation. Compartment syndrome. May develop due to increased pressure within the forearm compartments. Shaft ulna and radius. Published by WordPress.com. Management. Goals. Restore anatomical reduction. Maintain radial and ulnar length and alignment. 1. Conservative treatment. Indications. Non-displaced fractures. Nightstick fractures with less than 50% displacement. Less than 10 degrees angulation. Pediatric patients based on age and angulation limits. Less than 5 years, 20 degrees angulation. 5 to 10 years, 10 degrees angulation. 10 years, no angulation accepted. Methods. Long arm, well-molded cast for 8 to 10 weeks. Elbow flexed to 90 degrees. Forearm positioning. Proximal 1/3, supinated. Middle 1/3, neutral. Distal 1/3, pronated. 2. Operative treatment. Indications. Displaced fractures. Failed conservative treatment. Restore radial and ulnar length and rotational alignment. Methods. ORIF, plates and screws. Radius. Henry's approach, volar or dorsal. Ulna. Subcutaneous border approach. Plates. 3.5 mm small DCP. 5 cortices on each side. Plate removal after 15 months to prevent refracture. Intramedullary, IM, nailing. Indications. Open fractures, segmental fractures, or pathological fractures. External fixator. Indications. Open fractures, burns, infected non-union, or bone loss. Complications. 1. Compartment syndrome may lead to Volkmann ischemic contracture. 2. Non-union or malunion. 3. Refracture. Risk factors. Early plate removal, less than 15 months. Large plates, 4.5 mm. Comminuted fractures. And 4. Cross-union, radioulnar synostosis. Risk factors. Crush injury. Severe displacement. Delayed surgery, greater than 2 weeks. Fixation of both bones through a single incision. Prognosis. 1. Distal 1/3 fractures, worst prognosis. 2. Middle 1/3 fractures, best prognosis. And 3. Proximal 1/3 fractures, intermediate prognosis.